we were doing a course. We do a residence and medical students and fellows anatomy course every year in March, and we'll be doing that again this March. We've been doing it for many years. And when we had this course, this company called Synaptive Medical came in and contributed to the course to allow us to have residents. And they brought their device, and we became very interested in it. And many of us actually flew to their main headquarters in Toronto. And we began to see that this company is about innovation. And the idea behind this is that the eye may not be our best source for surgery. That is maybe only one tool of many. And so I think I'll just kind of go through this somewhat prepared talk that I did not write. And please stop me at any time. Has everyone that's here, have they actually seen the camera surgical instrumentation? Has everyone here seen it? Not at all. Oh, you're in for a treat. It'll be fun. I think that, so the idea behind it, before we get too far, is this thing that we're going to practice on today is like 10% of the company. And the company, probably Jason should speak about this, but the company really originated about MRI technology and about imaging. And they've brought that to a surgical visualization instrument, essentially, that we can use. But there's so much more that's about the company and that's about this instrument that they're just slowly adding on to as we go. And we'll talk a little bit about that. So we're here today. We have some people to help us. One of the most experienced surgeons in our group that's used Synaptive is Mark Moisey, who's you're gonna be here for a while. And Mark, somehow we can't get him off the thing. He's here in the lab a lot, as well as in the OR. So he'll have some comments to make. And then Dr. Chapman's here, who's been using Synaptive, and Rod Escuin, who, I don't know, he may be under snow in some avalanche somewhere, but he's supposed to be here. So what we're going to do is we're just going to do a little overview, and then we're going to get right into the lab. And that's what we want to do. And we'll have some lunch, and we'll go a little bit more in the lab, and then we'll call it a day. So I'm not sure we're going to go all the way to 3:30, but we'll see how long you guys want to play with this instrument. So I'm going to talk a little bit about concepts and technologies for planning, about optics, the robotic microscope, essentially their device, and some information about DTI. And we'll also talk about what excites us about the technology and procedural workflow issues and learning curve obstacles. So with any talk, I'm supposed to have disclosures, and my only disclosure is that Jens Chapman's a pain in the ass. But that's about the only disclosure I have. Oh, and Rod Escuin's a pain in the ass. Okay, so that's my two disclosures. Rod just showed up. Hey, Rod. So why have we adopted these new technologies? And I'm going to speak for SNI more than anything. We want to be, as a group, we want to be on the cusp of new things. And the microscope, which is a great tool, we all use it, is this big octopus that's heavy and it's in the room. And we're fairly limited by having to be in this particular position, which may not be the best for our neck. I've had an ACF, probably related to lots of microsurgery. And very few people really know what we're doing in the operating room. It's not like the entire team can see what we're doing. And we have also a very limited field where we're looking down a little hole. And it's dependent upon, the light's dependent upon that we get the light exactly right, and if we go around edges, there's shadows. And it's just a device that we've been using for an awful long time, but perhaps it's time to start thinking about new ways, and not only new ways about how to operate, but new ways how to think about what we're actually seeing. Because we only see so much, we see just light. And with a camera, with technology, we might be able to go past the scope of white light. So we saw this device and we wanted to get in on it, and it's still being in the development stage. It's actually changing monthly, and it's because the company is very interested in listening to the surgeons and change. So I think all of us have a broad interest in imaging, and this company is about imaging, and this device is about taking imaging and putting it into the operating room. And we're very interested as neurosurgeons in stroke and spine. We have our neurotology group here who's very interested in hearing and cochlear implants. But it can be a value for lots of other things, and potentially it might be a value for even things that we aren't operating on, like functional degenerative conditions such as Alzheimer's and ALS, and we can talk about that later. So our current technology, as I said, is either loops, our eye itself, or a microscope. And when we're using a microscope, it's frequently I see somebody like Dr. Moisey in this kind of position where he's not very comfortable. But we try not to do that, but it is ergonomically not the greatest, and sometimes our visualization is too narrow. So I don't know if any of you have had this, but you start operating and you're removing a lesion, a tumor, let's say, and then there's all this pool of blood, and you can't figure out where the pool of blood's coming. It's because it's coming from somewhere else and draining down into the hole. And it's because we have such a narrow field, and then we have to move the scope and look and find it and stop the bleeding. Where, as you'll see with this device, the field is much larger. So even though you can concentrate on the center, you really can see all around you. And I think that with time, because there's a learning curve, it's actually conceivable that surgery could even move more quickly. Not at first. So this brings a segue. So you see in a larger field a view, and it's in focus, and it's got a crystal clear image. And the reason why is with these cameras that they have, and they're actually coming up with another version soon, which will even be higher magnification. With these cameras, they have a much larger focal length. So, I'm an old guy, and my lenses don't move as well as I'd like them to, and I'm constantly focusing the microscope. But with this device, you don't have to focus as often because it's in focus down deep as well as on the surface. And so there's less futzing with focus because it has a larger focal length. And you can essentially operate in any position you want because you're operating with the screen in front of you rather than having you look right down the tube, the microscope. So, and with this device, it's possible to bring the camera in to a particular surgery in a direction or angle that might be very difficult for you to be in for very long doing surgery. I haven't done one yet, but I can't wait to do a sitting craniotomy and see what that's like, because for the surgeons, the sitting craniotomy is torture. And it's torture because your hands are up like this, and after 5 minutes of holding your hands up like this, you just want to put your hands down. And so it's really, for me, it's a tremendous exercise in muscle strength. And with the sitting position, I think that with the camera, we won't have to we can be up closer, and we won't have to have our hands like this. We can actually be operating like this. So I think there'll be some tremendous advantages for some of the surgery. And as you guys play with this today, I watched other surgeons as they play with this, they get very, very excited about it, and then begin to talk about all these ideas. And the Synaptive team takes notes, and they're very interested in all these ideas. Not every idea works out, but they're very interested in making this a device that's quite unique and that everyone wants to use, because that's how they make money. So the standard thing that we do nowadays is we we have a lesion, an interparenchymal lesion in the brain, most of us get an MRI. Most of us use a navigation tool, and then we take the person down to the operating room, and we register the navigation tool, and then we take a piece of bone off, and then we begin removing the lesion or using the tool to get to the lesion, remove the lesion, and then most of us take the probe and kind of touch around the edges and go, looks pretty good, let's get out of here. Okay, that's right? Okay. And most of us, I don't want to say all of us, could be all of us, but most of us also have been trained by the old professors that and it is true for a lot of things, but most have been trained that you know, the shortest distance to the lesion is the best. So find out where this lesion's closest to the surface and go that way. And that's probably true for most of us, is that's our thinking, oh, well, look, it's closer here, let's go there, it's less brain tissue. And so that's kind of where status quo is at this point in time. But we want to think about other ways. So we want to advance the state of the art. And so we want to take navigation. We want to take our understanding of the function of the brain, you know, with all this new information about tracks, DTI, you know, perhaps maybe going the shortest distance, but going right through the motor strip or right through some tracks that have function for maybe the hand or the leg. Perhaps that's not the best way. Perhaps we have to go a more circuitous route and miss those tracks. And I think with this particular technology, I'm going to kind of go off these slides, but I think with this particular technology, what is going to happen soon is you're going to get imaging. The imaging is going to be quite exquisite and be completely transferred to you immediately. And you can do your own, you know, you can be the pilot and do your own surgery. But the way this company's going, they're going to actually offer you one or more solutions of how to get to a lesion with the least amount of potential deficits. And so I could see us becoming more and more technicians and technology helping us figure out where to go and how to get there. And I think that's really, really exciting because perhaps, you know, we have not been thinking as well as we should, and I think we're catching up with some of the technology because, you know, when I was in training, we didn't really have navigation. Navigation came after I started training, about halfway through my residency, and we didn't have tracks and DTI till just really recently. And so the shortest distance was the way we thought for most of these things, but that may not be the right thing. And then if we have a company like this with a camera, high definition, magnification that's really quite incredible, and the ability for it to tell us where not to go and where to go, you can imagine that it isn't too far of a step before we're operating almost from home, where we have robotics and we actually can have tools move for us through the camera, and we can do surgery without maybe even gloves. You know, you can imagine getting that far, and I think this is the step where we're getting there. We're going to get there. Now, I don't know if I'm going to get there in my career. Depends on how much of a pain in the ass these two guys are, and I pop my aneurysm or something. But I think that there's a chance we might, just in the next 5-10 years, have the ability to do surgery with high technical ability and use a robot in this surgery. And this company and this kind of thought pattern, I think, is the avenue where we can go. So they want me to talk about a bunch of different things. I don't know. They want me to talk about the bright matter bridge. Prior to the bridge installation, hospitals had a 30% failure rate of MRI scans. Now with the bridge that they will put in, that shouldn't happen. So what that means is, for what they're trying to get me to say is that with the ability to really come into the hospital and educate the MRI system, they will be able to tell you if the MRI is of high enough quality to be used in surgery. I don't know if you guys have had this, but I've come down to the OR, we're doing a transcendental or something, and you know, I'm going to use stealth, and I come in the room, and the fellow says, Dr. Delashaw, we can see the tumor on the MRI, but they cut the nose off on the pictures. You know, we're not really going to have navigation. Well, why don't we go get an MRI? Well, Dr. Delashaw, I didn't really figure that out until patients asleep and they're pinned and they got cocaine in their nose, and you know, I'm like, and I won't say what I say, but and then we have to come up with the old fluoro, you know, kind of thing. And so that kind of stuff we can't avoid. And maybe some of you guys never see that, but I've seen it many times where I come in and what I thought was going to work out the way I wanted it to didn't quite work out that way. So let's see. Let me. So as I've said, this company really began with MRI Technology. That's how this company began. And then they said, how could we take this technology and bring it to the OR? So they're very, very interested in taking MRI technology and moving it to the OR. And as you see, they'll talk to you about this. They're very interested in tracks. And they're very interested in defining what is important to you guys as surgeons. So I have these images, as you'll see on this device, that you know, this is not far off. This is probably this year, where you can plan the surgery, and when you're getting close to the edge, it can actually give you a auditory signal saying, "Bells a stop, danger, danger," you know. Or you can identify, for example, if you have a meningioma with the middle cerebral artery in the middle of the meningioma, you'll be able to set this up and tell this device when to warn you when you're getting close to the middle cerebral artery. And so you can be maybe even more aggressive than before, taking the tumor out when you're getting close. And, you know, it potentially could be going, "Mark, you're 2 millimeters from the middle cerebral artery. You're 2 millimeters. Oh, you're 1 millimeter. Be careful." You know, that kind of thing. That's all possible here with the technology that they're doing. But the other thing that, let's see if we can get to it. A lot of these slides are kind of, I've already talked about most of this stuff. The other thing that is interesting is that they've been looking at white light. Okay, and we see white light, and what we use with that is we're taking out a glioma, for example. We're taking out a glioma. You know, most of us we take out the glioma with our eyes, and we get to near the end, and then we take the navigation tool and we put it on there, and we go, "We're pretty good." Yeah, you know, right at the tumor edges. We're pretty good, right? Right? You know what we do? Okay, and then, you know, oh, there's a little piece there. Okay, and then we get out, right? And then we kind of go, well, you know, everybody uses navigation. We can bill for it. Yeah, it's probably pretty good, but most of us are thinking, I don't know if we really needed it for this. You know, my eyes are pretty darn good, right? For most of the cases. Maybe not a low-grade glioma, but for most of them. So they have some very interesting information. This company's able to refract light. And just by the difference of refraction of light between normal white matter and abnormal white matter, they have a different reflection from the light. And so the potential here is, and I think this is right here, it's going to happen, is that the camera machine can actually tell you when you're at the edge. as you're taking the tumor out. And they can tell you right on the screen. You know, when I do navigation, you know, some people put it in their lens, but it's really painful. So when I do navigation, if I'm on the microscope, I'm removing things, whatever, you know, and then I put a probe, and then they go, the microscope is blocking the camera. You can't, you know, you can't. So then I kind of adjust it with the probe. Microscope is blocking the view. Damn it. So then I hold it like that, pull the scope up, and then I look up and see, oh, okay, and I put it back down. I don't know if you guys have done that, but that's, you know, you're not gonna do that with this thing, because it's incorporated into the camera. And you're actually having information over here and then the main screen right there. And it's gonna be so much easier to use and retrieve that information. And you're not gonna have all this blocked stuff going on, because it's right inside the camera. So the optics for this is really quite incredible. So I think you're really going to have fun here. So again, the device really that they have today, tell me if you have other things. The device they have today is this camera, and the camera that they have right now is a storage camera, right?
Well, we have our optics lens.
Yeah.
That connects to whether you have a striker camera or a source camera. Our next generation that's coming out is going to be a fully integrated camera. It'll be 12.5 times off, 5 microns. So right now, it's whatever camera system you have.
Yeah. So it works up to a camera, and you see the image, and you're looking on a big screen, and you guys can play with this, and it's also incorporated into the navigation system. And you can do anything you want with the screen. So you can take the screen and you can put a little quarter of it, and you can have the navigation right there in your screen, and because it's so huge, the view, it's not going to bother you with surgery, but you can actually still see it and not have to look up and you do all these goofy things. Or you can make it a half screen. You can do all kinds of different things you want with the screen, and these are big monitors. And everyone in the operating room is going to see what you're doing, which some of us might be scared about, but most of us probably like. And so you're going to be able to use those tools together with your eyes. It's much easier than having like a little piece in the optical. Does any of the surgeons here actually have like their navigation thing in their microscope? Anybody? They did offer that at one time, right? Nobody really uses that. But with a screen, you'll want to use that. You'll find yourself that it's helpful, versus when you're just like this, it's not very helpful. It tends to block the view. I've been up to Toronto, and the camera that we're talking about that they're going to soon use rather than the storage of the striker camera, the magnification is, what's the total magnification? 40x?
12.5 times optical zoom, and scaled down to about 5 microns.
Yeah, so they can up to 5 microns. So it's
twice the magnification.
So it's kind of it's for us, it's too much magnification. But you have the variability from just having very minimal magnification to this incredible amount. Now, as we get higher and higher in the magnification, we find out, particularly with guys like me, that we have more and more of a tremor. So, you know, you have to find the level that you want to be. But as I was telling Jason last night, was that the magnification is so incredible. So if you were like trying to peel something off the optic nerve, or maybe the carotid, the magnification is so incredible with the new camera that will be coming, is you can begin to think about inserting robotics into this and begin to be able to, let's say, scrape something off the carotid with robotics and not have a tremor. So you can see how this all could sort of develop into a whole different field of surgery. Let's see. Oh, we don't need to talk about that. Well, one of the things we do want to talk about is light, though. So several things about light. So with the microscope, you have your eyes and you look directly into the light. And if you have a assistant, they get half the light. It cuts the light out. So I don't know if you guys noticed, but if you have, like, you're doing a craniotomy and you have an assistant, and you're the assistant, and you're looking through, and you're seeing things, and then you say, hey, let me look in the main lens, and you go, holy wow, you can really see. It's because half the light's cut out, because it's a beam splitter. When you're doing spine, not so much, because they're looking right down the same one as perpendicular. But with the camera, the light can be markedly amplified over the microscope, and everyone's seeing the same thing. So you can have more light, and everyone can see the same thing. And again, potential technology here, not here yet, potential technology here is we might be able to see more with less light. For example, how many of you, you take your camera, your iPhone, let's say, or your Android, and you take a photograph. And you take a photograph, and in the old days, you had like a flash bulb. But most of the time, we don't even do a flash. Even in a kind of a darker room, we get a pretty good picture, and we can enhance it, right? So if it is kind of dark, we can go through with images and enhance it. Well, with all this kind of technology, it's capable of doing that too. So we may be able to use even less light, or take the light we have and amplify what we want to look for. These are all things that you can work with in a camera kind of system versus just a eyeball system. Does that make sense? So where we're going is really quite phenomenal. And I did mention depth of field. So you have a much higher depth of field when using this machine. And in some ways it's like an endoscope. You got a camera that you're using. That's what an endoscope is a camera, right? The difference between an endoscope and this is that the camera's back here rather than up in the front. And that has advantages and disadvantages. In an endoscope, you can kind of go around corners. The camera still can't quite go around corners. But the other difference is that with a camera, you have two hands. With an endoscope, you have either another guy holding it in two hands, or you have one hand. So there's some pluses and minuses, but there's definitely some advantages. Now, the way the device works is it will move for you. So you don't have to like manhandle it or anything. You got the camera there, and you can label a particular instrument. Right now it's a probe. I think we got a sucker today.
Right now we're waiting on it. It was supposed to arrive, but because of all this snow and so on, we're not sure where to find it right now.
So, but they're developing, instruments that we use in the OR to be your device. So essentially, right now we have a probe. So you put the probe in, you put it at an angle you want to look at, and then you hit a button, and the camera just moves right to look down where you want to go. And there is a learning curve with that. But eventually, the one device that we've kind of been talking about is a sucker. Everyone likes a sucker in their hand, at least the neurosurgeons do. Does the orthopedic surgeons like a sucker in their hand? Yeah. And so using that to basically tell the camera where to move will probably be extremely helpful. So, when you're sucking at this direction, the camera will move that direction, and you're sucking this direction, the camera will move that direction, if you want it to, just by hitting a button. Yeah, you might. Now, there's a movie about some guy fell in love with a computer, right? And Dave, this is Dave Hanscom, one of our orthopedic surgeons. And Dave, with your wife being in San Francisco, we just don't molest our device, okay?
So, Johnny, are the instruments then tapped like you do with stealth, for example, with this instrument that you're using, followed by robot?
These are all potentially possible. Right now, this is a pretty new company. This is a probe right now, okay? But they're coming out with a sucker, several sizes of suckers. But potentially, I've actually asked them to make a micro bayonet. My idea behind that is like splitting the Sylvian fissure. Is as I split the fissure, I just use a bayonet and I split the fissure as I kind of move the angle. I could just with my foot hit it and the camera move a little bit and I keep going, kind of thing. And what's really fun right now is they're a new company and they're very energized. So people like you could actually get highly involved in the development of where this thing goes. This is just the beginning. Okay, so I want to talk about negativity. Okay, first, the OR staff. You bring this device down to the OR staff. It's totally new. It's totally different. And you need to think about where you're going to position all the staff, anesthesia, nurses, the docs, the patient. And you also need to think about where you're going to put all the monitors, you know. And so it's fine, but it takes a little effort. And people on a Monday morning at 7:30 don't want to put an effort in. They just want to do the case. So there is a learning curve here of just on how to do this. And, you know, sometimes it's almost opposite. So, you know, you may want the camera and everything on the left for a right cranie versus the camera on the right for a right cranie. You know, you got to think about all this, and it really will be probably to your taste more than it is to anyone else's. But you need to think about all this instrumentation. So one of the negative things is everyone has to learn how to use the device. And so that's a negative versus just walking in, using the scope, and going home. Now for me, it's not really a negative because I'm kind of getting bored with just coming in and doing the same old, same old. This is really fun for me because this is like a new experience. And I think we're going to do things we've never been able to think we could do. But that's one of the negatives. The other negative is, for like Mark Moisey, it's probably not a negative. Because I think Mark, you know, he's pretty much a nerdy guy. I think he probably, when he was 14, 15, I was chasing girls. I think he probably was just sitting there doing video games. Okay? So for Mark, you know, looking at a screen and using his hands like this is second nature. And so he's loving life. For me, you know, I'm used to kind of looking directly down. And so I have to learn a little bit more about looking at the screen. And I do endoscopic surgery, so I got a little bit of advantage. But if you haven't even done that, you know, it takes a little time to be looking at the screen rather than looking straight down. And so there's a learning curve. The other disadvantage to the device is, and we're getting better at this, is that the camera sees the image, and if you're on the correct width side of the camera for spine surgery, it's not so much important for cranial, but for spine surgery, all the monitors show one view. We're correcting this right now, but all the monitors show one view, and we didn't really realize this. Again, it's a learning curve. So Mark was doing a case with me. We're just doing a lumbar disc. Was it a lumbar disc? A Lamy. Okay, we're doing a Lamy, and we get in there. I'm having fun, and I go, "Hey, Mark, here, take the kerosene." He's on the opposite side. Take the kerosene, and take some of the Lama off. And Mark puts the kerosene in, and it's like, instead of where I wanted to put it, it's like way over some other place. And then it's like moves way over to another place, and then it moves over to that place. And I'm like, has this guy been smoking or drinking? What's going on here? Well, it turns out that he's coming from the other side of the body, and the camera's only looking from the other one side. So up is down, down is up, left is right, right is left. So, you know, so we're changing that now, and the system will be so that if you're on the right side, it's like you're looking on the right side. And the left side, and they have, right now they have an inverted monitor, but they're actually going to fix it so the camera splits the images. One's inverted, one's not, so you don't have them. But see, we're learning. So those are another disadvantage. Rod, do you have any things about what the disadvantages are of the things as far as learning?
I think you just have to get used to I think the real, as Johnny pointed out, I think one of it's new technology, so you just really have to get used to sort of not looking down the microscope. And, you know, I haven't done as many cases as Johnny, but, you know, just it's a different feel. But once you get used to it, it actually, it's a lot, I think it's a lot more natural than using a microscope. And so, you know, and I think if you go back to, you know, like the early days of the microscope, it's it's just a different feel. But I think when you get comfortable doing it, it's actually more natural. Like I said, you know, I don't do a lot of cranial, but you know, if you're doing navigation, it's almost impossible with the microscope. And so, I think just the spatial, you know, and looking at your not looking at the field, but actually looking at the monitor and not really worrying about is. But you get used to it. It's kind of like a video game. You get used to that. And it's a lot more natural.
So one of the other disadvantages, though, and this is one of the major learning things, and today you'll see this, is that we have a much longer focal length. Things are in focus. But as a consequence, we don't have as much 3D. It's a 2D system. So when you're operating, you sometimes can't tell the superficial from the deep. And there's a little bit of a learning curve with that. And the actual way to do that, and you know, you have that with an endoscope too. So then if you do endoscopic surgery, this gets to be secondhand. But the way you want to do that is you put your first instrument in, you put it down to where you're interested. You take if you're going to use two instruments, you take your second instrument, and you touch the instrument that's down there, and your brain figures out depth, and then it's not too much of a problem. But if you just go off the camera and the monitor, you can't tell depth. It's two-dimensional. With a microscope, you have a little bit of depth, not a lot, but you have a little bit that makes it easier. And you also have a focus pedal that you can kind of focus up and down that helps you. But this is you'll see today. So we had Mike Lawton up here. He's a very well-known vascular neurosurgeon. Good buddy of mine. My dog's Michael Lawton. And we had Mike here, and he was doing an anastomosis. And it took him a little while to figure it out. And he's really good at it. It took him a little while to figure it out because, again, you don't have that depth perception like a microscope. So there are some disadvantages. Yeah.
Johnny, so you touched on it, but I don't understand, I don't see the vision for spinal applications. And I'm not sure what the vision is here for the company as to what we hope to accomplish with the spine.
Yeah, so for
how things are integrated, where do we see the advantages?
so and you'll get to see that today. So one of the advantages is that you higher magnification, you see more. Sometimes it's scary because now when I'm using loops and I'm doing surgery, you know, and I'm doing lami or something, but when I use this thing, the dura is pulsating. You know, you can see the pulsations of the dura. It makes me even a little bit more nervous sometimes. But the potential, you know, and this is really first designed for cranial work, but the potential for spine is you know, amazing. It can help you with parenchymal spinal cord lesions, potentially navigation with instrumentation. But the visualization that you can see is superior to the microscope.